Hello everyone. So in today's video we are going to study about menopause. This is one of the MCC objectives and it is objective for both QE1 and NAC OSCE. For NAC OSCE I would suggest to practice counseling on menopause. You could have a station where there is an elderly female who you have to counsel on menopause. Okay, and in that scenario you could also have a scenario where you have to diagnose the patient who's, let's say, 49-year-old or 48-year-old or 50-year-old, who's coming in with irregular menstrual cycle or hot flushes or night sweats, all those kinds of symptoms, where you have to pick that this is a menopause and then you have to counsel her on that. Okay, so make sure that you have a good grip on counseling. I would suggest you to have a conversational counseling session where you are educating the patient as well as you're asking the questions on what do you understand by menopause, what are you concerned about, if there's anything that you're specifically concerned about, what are you hoping for. So these are the kind of questions that you would incorporate in your counseling station for NAC OSCE. For QE1, we have to see what we need to know for menopause. Okay, so I'll let you guys know on that as well. But for NAC OSCE, you can also pick this definition from MCC objective where you have to explain the patient about what the menopause is. So you can use this statement here that menopause is defined as 12 months of amenorrhea after final menstrual period reflecting complete or near complete cessation of ovarian functions. You could state this and then you can explain it further in your counseling. Promotion of health maintenance in this group of women will enhance physical, emotional, and sexual quality of life. Objective relates solely to physiological menopause. Given a patient with physiological menopause, the candidate will be able to explain and prevent the undesirable effect of menopause. So you need to know how to prevent and manage the undesirable effect of menopause, like hot flushes, irregular menstrual period, cramping, heavy bleeding, and all those things. Given a patient with physiological menopause, the candidate will list and interpret history and physical examination findings, looking for atypical findings and risk factors for complications of menopause. Interpret investigations required for well woman examination. Construct an effective initial management plan where you are incorporating counseling, education of the patient of the normal changes during menopause, exploration and reassurance about psychosocial concerns regarding aging. So this is very important in regards to NAC OSCE and QE1 both. Psychosocial concerns regarding aging and sexuality. You would diagnose menopause very easily, but they will assess you if you're a good doctor in concerns to addressing the psychosocial concerns regarding aging and sexuality. Like patient may come up with dryness, itchiness down there, so you have to address these psychosocial concerns. And with itchiness, it could also lead to low mood, depressive symptoms. So all those things, if you would, they would really give you good marks on NAC OSCE if you would incorporate low mood or depressive symptoms in your history or counseling, asking the patient if he has any low mood symptoms. So that's a good thing on your exams. Counseling education of the patient regarding prevention of osteoporosis, one of the very key element of menopause that comes up with osteoporosis. Explaining patient why is it coming and what is the reason behind that, explaining the pathophysiology of that. Cardiovascular disease, discuss the risk and benefits and guidance of hormone replacement therapy. The talk of the town is hormone replacement therapy, where patient would consider the risk and benefit. Talking about topical estrogen therapy, why would you give estrogen therapy? Vaginal dryness is something that you would consider doing so. Discuss alternative to estrogen therapy for some of the symptoms of menopause. So now let's start with a Toronto note. So what I'm going to do is I will cover menopause from two different places. One is from family medicine, other is from gynecology, GYs 36, two places that you have to cover menopause from. So what is menopause? This is from family medicine, Toronto notes. Definition is 12 months of amenorrhea following the first menstrual period, final menstrual period. Mean age is 51.4 years. You don't have to exactly remember the age, but you should know. Associated with estrogen deprivation, urogenital tract like atrophy, vaginal dryness, itchiness, urinary frequency, urgency, incontinence, and bleeding. So recurrent UTI is also one of the clinical presentation. Vaginal dryness, bleeding. Vaginal dryness is very common. I've seen patients in clinic who are really coming in with a lot of vaginal dryness, atrophy. So that's one thing that we really need to know. Vasomotor instability, hot flashes, increased risk of heart diseases, bone loss, joint, muscle, back pains, fractures, loss of height, brain depressions, irritability, mood swings, memory loss. What is the management? Person-specific support and offering of the health education about menopause. First thing is education. Educating the patient on what menopause is and offering health education about menopause. Then you can also check this link that they have mentioned here. And then non-pharmacological management. Encourage physical exercise, smoking cessation, balanced diet with adequate intake, supplementation of calcium, vitamin D, and how much of calcium? 1200 milligrams per deciliter of per day of calcium, and vitamin D is 1000 IU per day. So calcium, vitamin D supplements, exercise, smoking cessation, balanced diet. Pharmacological therapy, hormone replacement therapy. Initiation of hormone therapy requires a thorough discussion on short and long term benefits and risks. So you cannot straight away start patients on hormone replacement therapy. You have to consider their symptoms, their risk, their benefits, their any medical risk that they are on. Okay, so let's say someone has a family history of breast cancer, uterine cancer, then you would be really careful on starting them on hormone therapy. Prescribed for moderate to severe symptoms for no longer than 5 years. So now the recommendation is moderate. If the patient has moderate to severe symptoms, then you would give them HRT for 5 years approximately. Routine use is not recommended. Regime is cyclical or continuous estrogen, progesterone, estrogen only, either estrogen only or a combination of estrogen, progesterone. If no uterus, patch, gel, creams, rings, and vaginal tablet. So if there's no uterus, then you can consider patch, gels, and all these things. Advantages: decreased risk of osteoporotic fractures and colorectal cancer. So we all know about osteoporotic fractures, that it reduces the risk of hormone replacement therapy is good for osteoporosis. But there is an additional benefit that they can test you on is the colorectal cancer. If a female patient is on HRT, that would also reduce the risk of colorectal cancer. Remember this. Disadvantage: increased risk of breast cancer, coronary heart disease, stroke, DVT, pulmonary embolism. So whenever a patient is on birth control pills or HRT, you have to ask about breast cancer history. You have to screen about DVT, bleeding disorder, coronary heart disease, stroke, pulmonary embolism. Why? Because it could lead to one of these. And then venlafaxine, SSRIs, and gabapentin to ease vasomotor instability. So patient who is coming with, let's say, hot flushes, low mood, depression, all those symptoms, you would consider starting them in SSRIs or SNRIs. Okay, you can also give them gabapentin. So that's that. Now moving to GY36, and also let's just check this link as well to see. Yeah, so that's another resource they want you to check for menopause. But I think if your health concerns, therapies, am I in menopause, what? So if you're preparing for NAC OSCE, I would highly suggest you to go through this, because here what would be different is that you would learn something new from here. Okay, so if you learn something new from here, you would incorporate that in your counseling, and that would really bring in a different. Let's say if you're incorporating getting a good night's sleep or anything from here, that would really help you incorporate new thing in your counseling, and that would make you stand out on that. Okay, so I would suggest you to check this link out, and this is the link, menopause-andu.ca resources. Make sure to check it for NAC OSCE. For QE1, I don't suggest you to go further ahead. There's this basic stuff that they want you to know, and you make sure that you know that. Okay, so now I'm going to move to GY36. GY36 here. So this is the second part of menopause, and now we have the treatment and we have everything. So let's just quickly go through this one. So FM43 we have already covered. Now menopause is lack of menses for 1 year. Timing of menopause is physiological, is average 51 year. Follicular atresia, premature ovarian insufficiency could be before 40 years. I've seen patients who are who have premature ovarian insufficiency, where their period stops coming in, and now they're earlier in their fertile period, and now they have no period. So that means they're in premature ovarian insufficiency before age 40, and that is the reason is autoimmune disease, infection, or Turner syndrome. Iatrogenic is surgical, radiation, or chemotherapy. Three different kinds of menopause: physiological, premature ovarian failure, and iatrogenic. Clinical features: vasomotor instability tends to dissipate with time. Hot flushes, flashes at night, sweats, sleep disturbance, formication. Formication is feeling that you have something crawling on your skin. So that is formication. Nausea, palpitations, urogenital atrophy involving vagina, urethra, bladder. Genitourinary syndrome of menopause. Okay, so urogenital atrophy, vagina, urethra, and bladder. So that is known as genitourinary syndrome of menopause. Dyspareunia, painful urination, and then pruritus, painful sexual intercourse, pruritus, vaginal dryness, bleeding, postcoital bleeding, urinary frequency, urgency, incontinence. Inspection may reveal thinning of the tissue, erythema, petechiae, abrasion, dryness on speculum. So just itchy symptoms, right? Scratching their skins would cause them abrasion, petechiae, erythema. Okay, skeletal osteoporosis, joint and muscle pain, back pain, skin and soft tissue, decreased breast size, and skin thinning and loss of elasticity. Psychological, increased anxiety, depression, irritability, fatigue, decreased libido, and memory loss. So these are the clinical symptoms of menopause. So they would give you any symptoms and they would want you to diagnose the patient and maybe manage the patient. So these are the two important things. What investigations would you do for that patient? For a woman with irregular cycle or menopause, let's say she's in her late 40s, or so what investigation would you do? If she's more than 45-year-old, no testing necessary. Okay, so they would test you if you are a good doctor and you know that, if more than 45-year-old female is coming, would you do any testing, or you would make it a clinical diagnosis? Because obviously menopause is one of the clinical diagnoses if it's occurring at the appropriate time. And what's the appropriate time? It's more than 45-year-old and by 55-year-old. So that's an appropriate time. But let's say if the patient is in her early years of, let's say, early 40s and mid 40s, what would you do then? You would definitely do beta hcg, prolactin, and thyroid testing. So 40 to 45, you need to know beta hcg, prolactin, thyroid. These are the questions they would test you on QE1. Okay, so you need to know these nitty-gritties for QE1. So more than 45 is no testing. 40 to 45, beta hcg, prolactin, and thyroid, 3 tests. Okay, less than 45, very young age, so you would also incorporate FSH along with prolactin, TSH, and beta hcg. Beta hcg to check if she's pregnant, FSH to check if she has enough follicular stimulating hormone, prolactin to rule out prolactinoma, thyroid to rule out hyper or hypothyroidism. Increased levels of FSH, let's say if it's more than 35 on day 3 of a cycle, if still cycling, and LH, FSH is more than LH. So FSH levels not always predictive due to monthly variation. Use absence of menses for 1 year to diagnose. Decreased level of estradiol later. So they have said, let's say if you're testing FSH and LH, if FSH is more than LH, that means she is menopausing, and if there is no periods for more than 1 year, because FSH and LH, they have variation in cyclical manner. Every month there is some variation. So it's not the most diagnostic one, but for menopause, FSH is more than LH. Okay, so you need to just to know that FSH is more than LH. I've commonly seen patients coming in their 40s, late 40s, and asking the doctor, can you please test me for the hormones? Can you please test my, I think I'm having menopause, if you can test my hormones. So we do prescribe them. We do write tests like FSH and LH. And in that case, we always need to know that FSH should be more than LH if you're considering menopause. Okay, so what test you're doing in late 40s? No test. Mid 40s, 40 to 45, you're doing you're doing TSH, prolactin, and beta hcg. And then early, less than 40, you're doing beta hcg, FSH, prolactin, and TSH. And then you also see the decreasing level of estradiol. So investigation you should need to know by heart. Treatment goals is for individual symptom management. Okay, so you know that menopause has different symptoms. Vasomotor instability, where she's having hot flushes, she's disturbed, she's having low mood. So you would give her SSRI or SNRIs. SSRI, venlafaxine, gabapentin, propranolol, acupuncture, behavioral modifications. Learn this treatment by heart. Okay, hormone replacement therapy as a first line. So hormone replacement is the first line. Then SSRI, venlafaxine, gabapentin, propranolol, and donidine. Acupuncture, behavioral modifications. So these are the treatment options. Then if there is vaginal atrophy, that is a local symptoms. That means you would treat it locally. Provide Vegifem cream. That is the topical estrogen cream. Okay, Premarin or estrogen vaginal cream, vaginal suppository, which is Vegifem, or ring lubricants. Okay, so you don't need to really know the company names. So we are giving the local therapy for vaginal atrophy, which is topical estrogen in the form of vaginal suppositories, ring lubricants, or intravaginal laser. Now, urogenital health, you have to consider lifestyle changes, weight loss, bladder training. Urogenital health means patient may complain of incontinence. So what you're going to advise her in that case, you'll tell her lifestyle changes, weight loss, bladder training, pelvic floor exercises, local estrogen replacement, or surgeries. Osteoporosis is we just have to consider calcium 1000 or 1500 mg once daily, or vitamin D, which is 800 to 1000 IU. Then weight bearing exercises, smoking cessation, and bisphosphonates like alendronate, SERMs, selective estrogen receptor modulators like raloxifene or HRT, and second line. This is very important. So for osteoporosis, you need to know the treatment. And in terms of important, I mean to tell you that calcium, vitamin D is one thing. Weight bearing exercise, smoking cessation is also another thing. Bisphosphonates. You need to know about bisphosphonates, alendronate, and selective estrogen receptor modulators as well. Raloxifene, HRT. So first line is for osteoporosis, you have to consider bisphosphonates and then SERMs, and then the last one is HRT. HRT was the first one in vasomotor symptoms. Vaginal atrophy was a local estrogen therapy. Urogenital health was mostly about lifestyle changes, pelvic exercises, estrogen replacement, or surgery. Osteoporosis, calcium, vitamin D, weight bearing exercises, smoking cessation, bisphosphonates, and then SERMs. And what's the name of bisphosphonate? Alendronate. SERM is raloxifene. And then the second line is HRT in osteoporosis. Okay. Decreased libido, you have to give vaginal lubricants, counseling, androgen replacement therapies, testosterone creams, or oral forms, and Driol. Cardiovascular, manage cardiovascular risk factor, mood and memory. By risk factor, they means giving statins, controlling blood pressure, lifestyle changes, all those things. Mood and memory. So if it's mostly cognitive related mood and memory, then you have to go for antidepressant first line. SSRIs, SNRIs, venlafaxine, and then MHT. And then menopausal hormone replacement, augment, and also CBT. CBT is very essential in anything related to mood. So treatment guidelines, I will just do follow the lines, and then the side boxes will do it later on. Okay. So treatment guidelines is primary indication is treatment of menopause symptoms. Vasomotor instability is the first thing. If anyone has vasomotor instability, you would consider giving her HRT on the first line. Should not be prescribed if the only objective is prevention of chronic. So you don't have to prevent the chronic disease considering giving the treatment. You have to consider treatment if the patient is symptomatic. Okay, for menopause, always remember give treatment only when the patient is symptomatic. Before starting, review the benefits and risk. Contraindication with the patient. Use the lowest effective dose. Patient with standard dose should be advised to lower dose after a few years. So you don't have to, try to be very careful with giving HRT because it has got its own risk and benefits. So you have to first see if the patient is symptomatic. You have to consider the risk and benefits of it and the contraindications with the patient, and then you have to start with the lowest possible dose and going titrating up to the dose, and then coming back to lower dose after a few years. Patient receiving hormone replacement therapy must be evaluated annually. So every year you should call the patient and ask her how she's doing, if there's any side effects she's having, or if there's any cardiovascular concerns or any histories of cancers in the family, all those questions. Okay. Decisions about duration of the treatment should be individualized, but recommended to avoid treatment for more than 5 years with a combination estrogen progesterone treatment due to duration dependent risk of breast cancer. So let's say if you have started her on HRT, let's say at the age of 50, you're calling her annually in the office to reassess her, and then by 55 you need to stop the HRT considering that she is now at high risk for developing breast cancer because of HRT. So after 5 years, consider stopping the treatment. Tapering and abruptly discontinuing HRT have similar impact on symptom recurrence, but for patient with a history of severe baseline vasomotor symptoms, gradually taper is probably preferable. So like steroid, you're also tapering HRT, not just stopping gradually because she would have the vasomotor symptoms again. Benefits and risk. So what are the benefits? No reduction of vasomotor symptoms, reduction of sleep problem, mood and anxiety problem, reduction of aches and pains, osteoporosis prevention and treatment, reversal of vulvar vaginal atrophy. So vulvar vaginal atrophy is reversed actually, and osteoporosis is prevented. Okay. Local estrogen therapy recommended if such atrophy is only indication for the therapies. If she's only coming with vaginal atrophy, itchiness, dryness down there, you just have to give her local treatment, not HRT for that. HRT is only first line for vasomotor symptoms. For local symptoms, local estrogen. For osteoporosis, first line vitamin D, calcium, and all those things, and then bisphosphonates, and then SERMs, and the second line is HRT. Now, what are the risk of HRT? Risk of HRT is thromboembolic events, stroke, breast cancer. Breast cancer increased risk after 4 to 5 years with estrogen progesterone regimes. No increased risk for at least 8 years with estrogen alone. So let's say if you're giving combination of estrogen progesterone, by 5 years you need to stop it, taper it down and stop it. But if you're just giving estrogen therapy for 8 years alone, then no risk of cancers with that. Okay, no increased risk for at least 8 years with estrogen alone. So let's say if she really needs it, then you can consider stopping progesterone and just giving her estrogen. Coronary heart disease for women more than 60 and those with who are more than 10 years after menopause. So after 10 years of menopause, more than 60 years old, they are at risk for coronary heart disease. Endometrial hyperplasia and cancer with estrogen only regimes. So Progesterone may cause breast cancer, estrogen may cause uterine cancer, okay, endometrial hyperplasia and cancer. So you need to remember this. Progesterone is a risk factor for breast cancer because even for 8 years, if patient is just taking estrogen, she's at reduced risk of breast cancer. But if she's just taking estrogen, then that increases the risk for uterine cancer as well. So have a good grip on this concept, okay. Now, hormone replacement therapy, estrogen, oral or transdermal patch. Transdermal preferred for women overall, especially with hypertriglyceridemia or impaired hepatic functions, smokers, women who suffer from headache associated with oral MHT due to decreased risk of thromboembolism. So you can consider transdermal patches, which is also kind of topical ones instead of giving it into oral forms. Low dose preferred dose, Premarin, Estrodot patch can increase if necessary. Progestin given in combination with estrogen for women with intact uterus to prevent development of endometrial hyperplasia. Progesterone is protective for uterus. Okay, progesterone is protective for uterus. So you have to combine it with the female with risk factors of uterine cancer. You have to combine estrogen and progesterone because estrogen alone can cause uterine cancer. And for women with increased risk of breast cancer, you have to combine estrogen with progesterone. Okay, if you're giving estrogen alone, that's fine for breast cancer, but estrogen alone can cause uterine cancer. So that's why they have limited the HRT use till 5 years. After 5 years, you have to taper it off. Okay, if the patient does not have a uterus, let's say, then estrogen alone is fine. Okay, so now okay, moderate to severe hot flashes and night sweat. We're doing the flow chart now. Moderate to severe hot flashes and night sweat, and inadequate response to behavior and lifestyle. So first of all, let's say patient is coming with menopausal symptoms. You have done lifestyle changes, no response. Now you would start free of breast cancer, endometrial cancer. We know thromboembolism, congestive heart disease, coronary heart disease, stroke, TIA, and other contraindications to hormone replacement therapy. Interested in considering hormone therapy, yes or no? So first thing first, you have to screen her in terms of if she's breast cancer free, if she does not have history of endometrial cancer, thromboembolism, heart disease, TIA, and any contraindications to hormone therapy. So you would consider yes or no to hormone replacement therapy. If she had hysterectomy, so you would consider only estrogen. Okay, but you would not do estrogen progesterone options. Then why? Because estrogen is safe for uterus, but estrogen is not safe for breast. Okay, so let's say if she's free of contraindications, then you would do HRT, or you would do if let's say she has contraindications for HRT, then you would consider giving her low dose paroxetine, SSRI, or SNRIs. Paroxetine, venlafaxine, escitalopram, if no contraindications. Adequate control of hot flashes, continued low dose of paroxetine or other SSRIs. So you make it simple. First thing first, female with menopause coming into you, you need to consider if she is benefited with lifestyle changes. If yes, continue doing it. If no, she's still having the symptoms, you would ask her if she has any contraindications to HRT. If she does have a contraindication, then you will check if she has a uterus or she does not have a uterus. If she has a uterus, you can only consider estrogen therapy, then good for her. If let's say she has a contraindication to HRT and now she's still having this vasomotor symptoms, now you would do is you would give her SSRIs or SNRIs, paroxetine, venlafaxine, escitalopram. If let's say she has some contraindications to SSRI, SNRI, you would then consider gabapentin. So on the right side, if she has contraindication, avoid SSRI, SNRIs, consider gabapentin, pregabalin, or clonidine if no contraindications. So one option HRT, second option SSRI, SNRI, third option gabapentin, clonidine, or pregabalin. Okay. Now, and if let's say you have given SSRI, SNRI, she's not getting better with that, then you would go to second line, which is gabapentin, pregabalin, or clonidine. Okay, let's say if you are doing and if she let's say if she has moderate to severe hot flushes or night sweat, she does not have that. Okay, no. Then you will check if she has some local symptoms like genitourinary, vaginal dryness, pain, intercourse, or sexual activity. If no, then you would not give her HRT. If yes, then you will see if she's free of breast cancer, endometrial cancer, other hormone sensitive cancer. If yes, then you would go vaginal lubricant, moisturizer, consider low dose vaginal estrogen. If no, then vaginal lubricant or moisturizer. So even for local symptoms, you are giving her topical estrogen. So you have to ask her questions like breast cancer, endometrial cancer, or hormone sensitivity. Why? Because those hormones get absorbed through the skin as well. So you have to know if there is any contraindication. If she has, then you will just do symptomatic treatment like vaginal lubricants and moisturizer. Okay. Now, if she had a hysterectomy, I told you that you will give her estrogen. If no, then combination. And assess cardiovascular risk factors in terms of if she's at high risk, low risk, or moderate risk. If she's at high risk, you have to avoid hormone replacement therapy. If she's at moderate risk, then you can choose transdermal options. And if she's at low risk, then you can give her hormone replacement therapy. Okay. Discussions about duration of use, continued moderate to severe symptoms, patient preferred weight baseline risk for breast cancer, cardiovascular, and osteoporosis. Okay, that's that. Examples of HRT regime. So these are the example: estrogen only, estrogen transdermal, estrogen only vaginal. So estrogen only has three options: oral, transdermal, or vaginal. Oral are these options: Premarin, estrogen, estrase, estrogen only transdermal patches, or estrogen only vaginal. And then combine estrogen progesterone and combined transdermal. So combined form we have oral and transdermal patches. For oral only you have to give for estrogen only you can give oral, transdermal, or vaginal. Now side effects. And then there is another line just beneath the table which is current common practice includes using Mirena IUD is the progesterone component, levonorgestrel, 52 over 5 years, approximately 20 picogram per day. So you can also consider IUD in terms of HRT. Okay, that's one of the birth control that you can also consider for HRT. Side effects of MHT: estrogen has breast tenderness, nausea, headache, and bloating. Progesterone has mood alteration, breast tenderness, bloating, and sedations. Okay. Contraindications to hormone replacement therapy: acute liver disease, undiagnosed vaginal bleeding, history of breast cancers, known or suspected uterine cancers, breast cancers, acute vascular thrombosis, history of severe thrombophlebitis, and cardiovascular disease. So these are the absolute contraindications where you need not to give MHT. Okay. So even for NAC OSCE, if you're counseling the patient, make sure during the counseling they will assess you if you're ruling out the contraindications, if you're telling the patients about side effects. So for counseling station, make sure even for QE1 and NAC OSCE for both, they really want to know if you are number one able to make diagnosis, number two you're able to learn that patient needs investigations or no, and number three you are telling the patient about side effects and you're assessing the patient for contraindication. So these are the four major elements of menopause that you need to know. So absolute contraindication you should know by heart. Relative you need to know, but it's not something that, but absolute is something that you need to know. Okay. Liver disease, vaginal bleeding, history of breast cancer, suspected uterine cancer, acute thrombosis, history of thrombophlebitis, thromboembolic disease, cardiovascular disease. Absolute contraindications for hormone replacement therapy: if this pre-existing uncontrolled hypertension, uterine fibroid, endometriosis, familial hyperlipidemias, migraines. Family migraine is something that is commonly tested as well as in concern to contraindications. So if the patient, let's say, is coming in with migraine, she has vasomotor symptoms, she would rather consider giving her SSRI or SNRI, not HRT, since HRT is the first line for vasomotor symptoms. But with patient with migraine, you have other options like SSRIs, SNRIs, pregabalin, gabapentin, clonidine. Family history of estrogen-dependent cancers, chronic thrombophlebitis, diabetes mellitus, gallbladder disease, hypertriglyceridemia, impaired liver function test. So for liver function, you can consider transdermal patches. So this is one of the QE1 object question. This could also come as a QE1 question as well, like impaired liver function test. Now what would you do with her symptoms? You can give her transdermal patch for estrogen. Fibrocystic disease of breast. So anything related to breast, liver, and heart is something that is contraindications. Okay, so let's say if liver contraindication, then you can consider transdermal patch. So that completes this, and now I'm going to cover the right boxes. Long-term HRT for perimenopausal or postmenopausal. So we will jump to conclusion. HRT may be contraindicated for some women with increased risk of cardiovascular disease, thromboembolic, and certain cancers such as breast cancer in women with a uterus. HRT is not indicated for primary or secondary prevention of so it's not for prevention of cardiovascular disease, dementia, or deterioration of cognitive function. Okay. Osteoporosis is the single most important health hazard associated with menopause. Yes. Cardiovascular disease is a leading cause of death in postmenopausal women. Increased risk of breast cancer is associated with estrogen progesterone HRT, but not with estrogen only HRT. It's an object, it's a question. Learn it, and you need to know it. All women taking HRT should have periodic surveillance and counseling regarding its benefits and risk. Okay. So this is for NAC OSCE. You need to know the surveillance, counseling regarding its health benefits and risk, and contraindications as well. HRT and health outcomes during intervention extended post-stopping phase of Women's Health Initiative randomized trial. So let's just see if there's a conclusion. No. So what was the purpose of this study? To comprehensive finding from initiative hormone replacement trials with extended post-intervention follow-up. So result reported as per 1,000 stratified. So this was about giving HRT with additional risk and benefit. So I don't think so you need to know this for QE1. Let's skip it. And also we learned about HRT that they reduces the risk of colorectal cancer as well, right? Remember, in the family medicine. So that's an additional thing that you need to remember. Absolute contraindications to HRT is ABCD is a mnemonic, acute liver disease, vaginal bleeding, cancers, breast or uterine, cardiovascular disease, and DVT. Okay, so that completes the menopause objective. And if you have any questions, you can jot down below. And I hope you like this video. Thank you for watching. Do subscribe to my channel. Thank you.